One was the obvious need for sharing data across multiple sites and multiple languages, and we've talked about that already. But excuse me. But also for the importance of sort of integrating our system within the existing Ministry of Health systems. Excuse me. So one of the features of Millennium Villages then is the use of OpenMRS in primary care as kind of the main reason for using the system. Of course, we have TB patients, we have HIV patients, and so on. So we started essentially by building a much larger concept dictionary than was, we actually started with the AMPATH dictionary, but then sort of added in all of the diagnoses and all of the procedures and medications that might be relevant, and maybe those that aren't relevant, at least so we have a version in the database. And then we started to focus on several key features. One was the capturing of data. And I'm going to sit down because I'm going to encourage people who want to get up and either ask questions or participate to answer questions to come up and sit here as well. We basically wanted to capture the initial encounters that were occurring in our very rural primary care clinics. And so those could be broken down into either sort of adult visits, pediatric visits, or primary care antenatal slash family practice, family planning type visits. So there's we have three forms essentially that we're working with as a core. And then what we realized is that we needed to incorporate some vital registration work, because if we're working in these communities, we needed to really know what the denominators were. And so recording all births and all deaths in the communities, so birth forms, a death form, and then since we wanted to figure out more what was happening with the deaths, a verbal autopsy type form, so that we could actually capture more detail about the actual deaths. And our experience has been that it is a big leap to go from what they were currently doing in the registers to any kind of encounter forms, let alone, here's Hamish, let alone the kind of data that would be incorporated in a front and back page form of an encounter. But the experience so far has actually been quite good in the sense that the data that's being captured, particularly in our site in Uganda, where they have this wide area network and they have every single encounter being captured from 6 different facilities going into one single database, in terms of quality improvement has been huge. So there are plenty of, and we can get into this if you guys have questions about this, implementation issues about transferring, from an initial implementation going from a register type based approach to a much more medical record like approach. And again, I should mention that we're doing it retrospectively. We're not using point of care data entry. To also, I think, a question which is, when you've got an existing system using HIV or TB, how do you expand upon that to now bring in the additional questions and concepts and necessary workflows associated with primary care? And so, Hamish, just to bring you up, I just started, we thought we'd do a fishbowl approach. People get, we have people taking minutes and so on, to sort of set you up in that way. And so maybe you could say a little bit about kind of what your needs are and questions. And I really encourage you guys who either have concerns about this or have ideas about this to come up to the front. And if you don't, we're going to start calling on you.
We lost Evan to some other group.
You're welcome, Malawi.
Well, I guess Evan talked a little bit about his work yesterday. What I'm particularly interested in the types of data that people actually want to collect and how that data is used, because I think this issue has not been well defined. And for example, in Rwanda, we're still coming to a clear idea and consensus about what is the information that the government really wants to collect in a primary care setting. And clearly there's a big range in the way people use systems. What Andy's done for quite a while is actually collecting data related to individual patient visits. And James Arbar's project in Hospital Albert Schweitzer in Haiti actually collects individual patient visits as well. What we're looking at is a little bit more towards the type of systems that Baobab Health Trust has been putting together in Malawi, and in the collaboration we're doing with them. And there what we're trying to do is to use a more specialized approach of really particularly focusing on the patient's visit, knowing when a patient arrives and recording clearly what their ID is and actually creating a barcode of that ID, which goes on the health passport. Clearly this has a big advantage in terms of knowing who the patients are and knowing if they have follow-up visits. And then with that, you can then link that information to other sources of data that are collected on that visit. At the moment, what we're focusing on is diagnoses coded using a national coding system, which in the case of Malawi, I'm not sure it's linked to any particular coding system except ICD-9 loosely at the moment, but I may be wrong about that. In Rwanda, there's a decision to use SNOMED for the diagnoses. But to be honest, I mean, the kind of SNOMED system that Andy's put together, which has something like 30,000 concepts, is way beyond the level that we're looking at the moment. We're probably looking more in the region of 100 or 200 initially, and then building on that. The experience so far in Malawi has been pretty good, actually. We've got been able to get summaries every week, or intentionally we could do it daily, of the diagnoses that have been recorded in the patients, and that information is in fact entered by the clinicians directly using a touch screen. Most projects, of course, are actually going to have a paper form, basically an encounter form, and they'll put in the patient's demographic data, if it's not already known, and then they'll record some type of information about the presentation of the patient, maybe the presenting complaint, diagnoses, and in addition to that, drugs and any lab data that's collected. And one of the real prototypes of this would be the Mosoriat medical record system, which was kind of the foundation of the AMPATH medical record system projects. And that system is actually still in use. It's access-based, and it has a 1 to 2 page, I think it's a 2-page paper form which records the details of the encounter, and that's then entered into the system at the end of the visit. Clearly we could add other forms that collected a wide variety of data about the patient and their visit, but the reality of primary care, particularly in African context, is that there are very few staff to see these patients. So everything has to be done extremely quickly and efficiently if we're going to be able to actually collect data without slowing down or really damaging the workflow in the clinic. So while it's nice, and you unfortunately get, often people sit down in a room after a couple of beers and decide to write an 8-page form that would be fantastic with everything that anybody in the room ever wanted to collect. The reality is if you get beyond a third of a page for primary care, you're probably pushing it.
So actually, JJ, could you come up here? I'm going to call on you to talk a little bit about the Uganda experience specifically. The challenge that I think we have is, and I think, I'm trying to remember who actually brought up this earlier, but that the forms themselves, in a way, are a form of knowledge transfer and a form of quality improvement in themselves. And I think one of the things that we've been finding is that certainly the ministries themselves probably don't know what they want, and that the forms that they're getting often don't even correspond to what they want, and that thinking about what really should be on those forms or what kinds of data elements is kind of a balance between the things that they absolutely need to do for time savings on report generation, as well as the quality types of indicators that we need for improving the quality of care, as well as perhaps, what was the term we used for it? Aspirational goals. I mean, the things that people often feel that if things are not on the form, they're not important. But maybe what we need to do is there are certain things that need to be put on the form that we don't really think will be used that much right now, but would like to be used in the very near future. And therefore, by having it there, it's sort of a constant reminder. Eventually, they'll be trained. JJ, why don't you tell us a little bit about that kind of arc that you've gone through in Uganda?
In Uganda, we have 6 clinics, and we kind of started off just at one of them using just the inpatient and outpatient. Sorry, just the outpatient form for pediatrics and adults. And the initial approach was just to kind of collect all the information that I could find that was contained within the Ministry of Health report. There was a monthly report that we were required to submit. And then there was a daily register that they would use, which really just had demographic information and then diagnosis and treatment. What I ended up doing, or where we're moving to now, is kind of drastically reducing the amount of information that we're collecting. And I think that going forward, it makes sense to kind of look at how designing your forms in terms of what interventions you actually expect to do. We have, in most of our clinics, maybe 5 to 10 medications that are available, and many of those are not regularly available. There's only 2 or 3 lab tests that we actually can do. A lot of the information that ordinarily would be collected, really you can't do very much with. So although it would be nice to know a lot about their past medical history, their immunization history, there isn't really any process that's been in place to deal with any of this stuff. So one thing that we can deal with is malaria. So we have a rapid detection test for that, and we have a medication for that. So we've protocolized and held training workshops on how to follow the protocol, and it's been pretty successful. And now we're kind of trying to figure out what are the next steps, what are the most important diseases to look at. And I guess I'm using that as a framework. What diseases specifically should we be thinking about from the primary care setting?
Can I just clarify, 5 to 10 medications? It's probably about 150, really, isn't it? Or maybe 100.
At the clinics?
In the pharmacy.
They don't get, that may be on the essential drug list, but they don't get it.
We have maybe 3 versions of penicillin. We have Flagyl, and we have Bactrim, and we have Coartem. And then that's pretty much it.
So this is an important distinction, is that I think a lot of the the NGO-related work, we're in government clinics. We're essentially a supplement to government clinics, and that's the reality of in most of these places. So information is treatment. So at least we have information, and we're actually working in to some extent. This is an extreme example. Some of our other clinics are better facilities are better stocked, but places like Mali and so on, where there's even greater restrictions. But the point being that there is a need to focus on what's actually available and what can be used, with the notion that I think if you can identify gaps through the information system, that helps drive the need to actually get those supplies or to get those interventions so that you can give better care.
So I'm not surprised in the way that there are many drugs stocked out, but that number does sound pretty scary. But you learn things about this work, and I think that to follow Andy's point, in fact, there's an enormously important requirement to use information systems in primary care, particularly in a health service setting, to track critical fail points like this. And so if you really are stocked out of some of the most critical life-saving medications, which unfortunately happens very frequently, then I think this information needs to be collected and used from a point of view of supply chain and also from a policy point of view.
I'm totally, wow. My position, just to somehow help in this discussion, is that with the health system in Latin America, our focus is primary care. We've got a doctor with us in our organization who is a primary care leader in Latin America. She, for the last 20 years, she has developed primary care modeling, which is started a long time ago with the little resources. But I do encourage OpenMRS developers to really try to somehow communicate to the rest of the OpenMRS community that we move away from the forms. Maybe a model of care. We can actually try to help you to come up with the data elements in this form, because there's a lot of energy. There are different drivers in primary care. Firstly, in a budget point of view, primary care get the less money to provide primary care. From the point of view of evidence-based practice, to be more effective in the quality of service, we should go to primary care because it's more preventative, but the money is not there. Therefore, the logic is, whatever, I'm here standing here because I believe OpenMRS should have a module called OpenMRS Primary Care. But the primary care should be defined in a modeling manner first. That way my colleague here doesn't struggle to come up with forms who actually want very quickly to capture the data, but I think it's a short-term solution rather than a long-term sustainable solution. Therefore, I suggest with Dr. Veronica Rojas, we're developing right now some of those modeling that it may work or may not work in Africa and Asia. But if we put it on the table, then the discussion is open up for the model of care secure a primary care delivery at any point?
That ties in really well to a question that I wanted to raise. I'm working in Malawi right now, and so obviously influenced by Baobab and their focus on point of care and touchscreen software. So I'm wondering, it actually would be a great topic for another breakout, point of care versus retroactive data entry. But it's something that I think has a big influence. The issues really change first when you're going from a primary care, from like vertical programs to a primary care setting. The utility of point of care versus retroactive form entry, I think the issues change. And especially if you go to the extreme level of like, let's start somewhere before the idea of forms. Let's model, a model of care, and then talk about, interfaces or how we'll enter that data. Whether you're able to do a point of care system versus retroactive data entry really have a big influence on that. And so I was wondering, the implementation I'm working on is just getting started, but I'd be interested to hear if you have input about the challenges of point of care, the advantages that you see versus relative to retroactive form entry.
So actually, I think JJ could probably also add comments about that specifically, but let me take a step one back, because I think in terms of the goal of this group would be to actually come up with a set of either use cases or data elements or key things that need to be incorporated for primary care. I think that these sort of overall issues about integration within an information system to support people upstream is important. But then we've also mentioned how important that the information needs to be available locally, either at the point of care or within very close proximity to that, to help decision making locally. The Health Metrics Network has been putting out these frameworks to help strengthening information systems at country level, and has been really looking potentially to this community and others to provide insight as to how primary care or information systems that are at point of care can be used to feed into these other information systems. So I think we need to keep that in mind, that what we want to be able to do is kind of integrate in a continuum these information systems. So for example, one of the things that came up in our experience is that it's not just capturing the information of the drug given, which certainly is needed for supply chain management and things like that. It's not just the disease, because the disease is important for incidence. We've actually found out that you sometimes need to use the drugs to figure out what they really thought they were, because they thought they checked off diarrhea, but they gave them anti-malaria meds. You need to look at the tests, because we found out that they were testing people for malaria, and then the tests were negative, but they were treating them anyway. So all those kinds of things need pieces. But then even more interesting, what we found is it's important to know who referred that person. Did that person actually get referred from a community health worker, to actually track whether or not that referral process works? In the case of a clinic where they actually see a person who had fever and are given anti-malaria drugs, and then are told, well, we're not really sure this is malaria, you better go to the clinic or to the hospital and get evaluated because we think there might be something else going on. How many don't go? So actually kind of managing that process of care is also very critical. And just one comment on this, and then I think JJ's had a lot of experience with working with the data entry people there. The capacity required to go to a point of care system, clearly Baobab has proven that it works, so I'm not saying it's impossible. But in terms of being able to make these truly scalable and very rapidly, because Millennium Development Goals, we need to make some significant progress quickly, probably necessitates some kind of form-based system that interacts with an existing paper-based system, because we just can't do that. But JJ, why don't you talk a little bit about the human resources?
I think that
And again, let me remind people, please, if you want to say something, you have a question, please come on up.
for us, we're in an environment where there's no electricity. We run on solar. a point of care system using computers is just not possible. I mean, we do have data entry at 2 of our sites where we will run on the solar for as much time as we can, and then we'll switch to a generator in the event that power runs out, which it frequently does. But at the other 4, and you know, these clinics that we work at, they only have solar because MVP came in and brought solar. Any other government clinic inside of the district that certainly doesn't have solar. I mean, and they don't even have 10 medications. So, I mean, you have to kind of adapt what you're able to do based on those circumstances. And I think that it would be preferable to have a point of care system, but then you also have to worry about training your clinicians, and I'm sure as Beobab can speak a lot more about whether that's how difficult that is. But it's for us right now, it's just not something that we can actually do.
Come on up. You have to sit up here.
I just want to ask a question.
Yeah, no, you got to come and sit to ask a question, but you got to wait for after the speaking stage.
Yeah, a big part of kind of the primary care discussion kind of intersects with kind of chronic disease management. And if you leave primary care as just its own beast and you're going to record every piece of clinical encounter that comes in, you very rapidly get into a big mess because, you know, most of our data is recorded as coded, based on coded concepts. And most diagnoses, if they're not as part of a checked item in an encounter form, end up being just most likely a concept which doesn't exist in the dictionary. You get rapid explosion of your concept dictionary, it becomes difficult to maintain. So you can easily get into a big mess if you leave primary care to just kind of be its own beast. What we've done at AMPAT in terms of making the transition from pure HIV care to primary care is actually identify some medical conditions which are or at least clinical encounters which are amenable to kind of chronic, or which we think are more amenable to primary care, or at least creating encounter forms. So the big ones are TB, ANC encounters for antenatal clinic encounters for pregnant women, and well child clinic primarily trying to capture immunization information. But you can see that same kind of concept used for diabetes care, for example, hypertension. So there are particular elements where it could be easy to say, you know what, we can create these modules for primary care that can be reusable, create concepts for them, and record that information. How the form is designed obviously depends on how the clinic is. Some clinics have all the services as part of the same clinic, where some clinics are purely dedicated to one condition. Obviously, all of them can't have encounter forms that look exactly the same. And then the other issue is, can you take care of multiple providers by encounter, is the other thing that comes up. But that's kind of been our approach. Identify the core conditions that you want for your primary care. The other stuff can still be recorded, but the basic things amenable to chronic management are the ones you go by.
Just to support, we found 11 concepts in primary care, and it's exactly some of the example we come up with chronic management, maternal health. We can actually share that. It's 11 concepts, the most common, but what I gather from here, which I think it would be good, is some critical elements that might be useful for spot on, because I gather from the form gathering, it's much better to have some data than nothing. Therefore, it will be very helpful probably for like primary care, rather than wait for this modeling and maybe long-term thing, to have some critical data in order to move forward.
Okay, the question I wanted to ask earlier, you say your point of care, you'd like to be able to do the point of care. Have you looked at making use of PDAs, cell phones, other mobile devices that don't need the electricity? And then the other question I wanted to put up to the panel, for those who've got to feed into DHIS, where you're looking at your specific data elements that they're required to report on at a government level.
So I'll start there. First of all, yes, on most of those questions. PDAs, not so much for the facility-based data entry. That's something we've considered, although, again, the type of information that we're collecting has so far been a little bit much for what we can achieve on the phone. But the purposes of our community health workers and some of our baseline community data, absolutely, we're working with OpenRosa to integrate on that fashion. On the outbound side, very definitely, we're extremely interested and have been working on the DHIS integration piece. Several of the 10 different countries that we're working in, or 11 countries, already use DHIS, so it's kind of a no-brainer. But otherwise, I think there's a need to even demonstrate how periodic indicator reports can be automatically exported, and whether it's DIHS or the DIM system in Ghana or whatever. The last piece that we also feel is very critical to primary care, which hasn't really been mentioned yet, which is the reimbursement side, actually, and that's the insurance theme. Because typically the primary care clinics are ignored, and the hospitals get the money from the governments and so on. But we found, and this is what we're working on in Ghana, that just by actually being able to electronic report on the visits to clinics and the drugs that are distributed in those clinics will allow those clinics to have an income stream that they've never had before from the governments as part of the national insurance scheme. And so this can immediately pay for the equipment and for the training and so on. But those pieces are just now being built. Is there anyone from Baobab who would like to talk a little bit about this?
Rats.
Yeah. So another, I think, issue that was brought up that Martin just brought was the notion of collecting more granular data with a very broad spectrum. So first of all, it's true, primary care or any kind of internal medicine or perhaps even obstetrics care is going to mean a lot more diagnoses, and we do want to encourage people to accurately describe what the patients have, especially if we want to use this data over and again for other reasons. So the fact that a person has leukemia, for example, it's not very helpful to say that they have a blood-borne, blood-forming organ disease, which, if that's the thing that's on the form, we'd like to catch that they actually have leukemia. And so one of the things that we've done with the Millennium Villages project is we have created this very large concept dictionary. And the point is not to have people constantly going into that concept dictionary, but when they get to the task pane window and someone's written down other and has written leukemia, and they actually go over to the screen and they type in leukemia, they get leukemia. And they can actually put it into the record in a codified way. So, there's a balance between the actual having a narrow group for the purposes of coding the stuff that's on the forms, but having a large group for capturing what is in these clinicians' mind or writing on the form is the other side of that. The other thing I think I will mention that JJ hasn't yet mentioned, but I think is really important, is that the vast majority of primary care visits are not chronic care visits. It's a one-time sort of thing, and so there's not the kind of need to have a longitudinal record for someone who comes in with an acute respiratory infection. Now that acute respiratory infection may turn out to be TB, and so you do need to have it there. You need to have that data there, but you don't necessarily need to have the sort of all the previous data available for these acute care visits. And so it's a different requirement. That data is very important later for deciding what your main diseases are. But point of care, you don't need that data. And so most of the point of care data is the kind of recording of just what did I do, what the symptoms were, and so on, and not necessarily seeing their whole history in front of you. Sorry.
Just wanted to ask if you've started to think about in Rwanda how to integrate the data you're collecting with the community health insurance data, because in Rwanda that does exist at the health center level, and this is something we're now thinking about as we want to start collecting primary care data in Rwanda, and not necessarily have two completely independent parallel systems, but also from examining the Mutual data, realizing that billing data is not clinical data, and we probably have to do it in the other direction.
So that's actually really good. We've just started to look at this now. So in Ghana, we've gone a little bit farther and actually starting to think about actually generating an encounter form specifically to go to the insurance scheme. It's interesting that one thing that we've learned in the Rwanda situation is that the forms themselves, or what the doctor, or they're not necessarily doctors, what the nurses are asking for, is not actually what necessarily gets dispensed. And that the Mutual data is actually more accurate, because they only write down what they're actually giving out so they can charge for it. So it's interesting that we're now looking at maybe using, for the pharmacy, using the Mutual data directly entered into OpenMRS rather than having a form that's separate. But thinking about the actual way to pass electronically the data between the systems, or even in a true workflow, this is the area we can talk about, because I think that's an area we would love to think a bit more about. Unfortunately, we don't have the answers yet.
I was hoping.
So one of the things that has come up in that issue in Ghana, and probably in Rwanda as well, is the need. I don't know if people remember within OpenMRS that within the concept dictionary there were, or I think it was in the drug table, there was some cost data. There was a column which is not really populated. But the need to theoretically have either a interoperability relationship with another practice management system where the cost tables are kept, or think about having a module that would essentially add additional tables specifically to hold cost information. Both would be useful for the purposes of managing your clinic, obviously, but also for generating these forms that need to go to the Mutual or to the National Insurance Scheme. Would help to have that data. So anyone interested in doing that, or a developer who might be interested in incorporating those in some way, that would be helpful.
I'm hearing about the challenges of introducing the technology at the point of care, and there's obviously infrastructure challenges in a lot of places that may or may not be amenable to either SMS or PDA approaches. But one thing I would throw out there as an underlying thought is that oftentimes if you look at a clinic and how it's operating, and you hear about it being busy and they're overwhelmed and there's not this and there's not that. But oftentimes, if you examine how the clinic's working, you often find a way that technology like OpenMRS can address that. And in the States, the example I always use was that if you could actually measure the amount of time people in the clinic spent trying to find a patient chart when they needed it in a paper-based world, you would be stunned, because it's a clerk, it's a manager, it's a nurse, it's a physician, and all of a sudden to deal with one lab result, you've got 5 or 6 people running around looking for a chart, which is extremely time-consuming. So there's oftentimes processes that are very inefficient that technology can address, and that's kind of how you bring the technology to the point of care, I think, as well as getting your better data.
Andy, you brought up an issue of, and I know this is going on in Rwanda, but it's very likely in other countries as well, the kinds of information that is needed, say, at the policy and the planning level for a whole system-wide, and particularly thinking forward for forecasting new trends or issues that will come up, whether it's changes in malaria risk relative to climate, whether it's emerging diseases where it's that are coming out of the forest, interacting human populations. I'm just thinking on that broadband area. How do you design a total health information system that goes from the national down to that clinic base, so that you're not trying to get that frontline worker overwhelmed with collecting data that is going to deteriorate the service delivery, but how at the same time at the national level do you really ferret out what are the really critical things to get? I mean, are there, for instance, I can just envision that suddenly in certain areas there are changes in certain kinds of diarrheal diseases that might occur that could be indicators of some new kind of emerging disease or problem. A sudden outbreak of amoebiasis in a certain area that that maybe was treated as just kind of normal diarrheal things, but it's really an indication of something more. So how do we begin to think through where certain kinds of data, and maybe it's a separate system, maybe it's sampling systems from the top down, and then you have other front line to keep that data under control.
I think these are really important questions. I would say that there is probably too little emphasis on collecting the right data in the healthcare facilities. However, that doesn't mean that the doctor or the nurse who's doing all the clinical work is the one who should be doing all that work as well. But I mean, I think if you, this is a really, probably in here are some of the most critical examples of why we do this work, and also of why we need to evaluate what we're doing and to really analyze the data that we're getting. And I think Andy's one of the people who's really taken a lead in this process. If you have a situation, and I'm actually very interested in the whole drug supply management issue, and I've been reading a lot about the high levels of stockouts and so on. I mean, just to give you an example, a study from Johnstone International in Tanzania two years ago showed that 40% of the clinics in the intervention group, that was the good group, inverted commas, were stocked out of oral rehydration therapy. And there were similar figures in the 20s and 30s for amoxicillin and other really essential drugs. And unfortunately, that translates into large numbers of unnecessary deaths.
Right.
I mean, thousands, probably hundreds of thousands in Africa, maybe millions. And so when someone says, well, we can't really afford to collect this data in the healthcare facility, and you say, well, a large proportion or a large number of the people who come to your clinic with an entirely treatable disease are going out untreated, either suffering or dying, then you can't afford not to. So I think maybe this should be one of the key driving forces for collecting data on primary care. What are the most critical pieces of data that will help us to fix this broken system? And clearly knowing what's going on with the drug supply, knowing what the key diagnoses are, and just knowing who's coming to the clinics and whether they come back again may be enough to have a huge impact on that if that information is collected consistently and then is used. And I think that's a really important example where the frontline SMS example that came out in Kenya very recently of getting people who actually visited the clinics to text a special site warning about the fact that there was a stock out for the drug that they were prescribed. And that information was then sent to a server which mapped it on Google Maps, taken to the health ministry in Kenya and the parliament, who voted for more money for drug supply.
So this could be even for just critical outbreaks of cholera or other kinds of things. How do you catch those into a surveillance system?
So the question was, I mean, could you use this to pick up critical outbreaks such as cholera? I think that there's really an increasing understanding in the US, for example, which has a big interest over the last few years in sort of terrorism surveillance and disease surveillance, and now actually, to be fair, being used in a very effective way for flu surveillance. But there is a great understanding of the need to collect the clinical data at the point of care, particularly in emergency departments, and use that information for real-time surveillance. So I think that's another reason why this type of data, if it's collected appropriately, can be very helpful. And we're already looking seriously at that in Malawi now that we have real-time day-to-day collection of the diagnoses. But there is still, I mean, it's a real challenge because you don't necessarily have enough information to make very definitive diagnoses in a lot of cases. And that's something that to some extent, we have to live with. But also, by looking at that data and analyzing it, we should recognize what are the biggest gaps and then look at what other, for example, laboratory tests are required to really improve on the situation.
Yeah, I think that I just add a little bit to that in terms of the surveillance situation. There are two immediate issues that come to my mind. One is that it's oftentimes not possible within a given server or clinic to identify a change, and therefore it's important to aggregate the data in some way. The Google's predict and prevent and instead, I believe, I'm not sure one's here, but the point there was to try to create systems where that analysis point happens lower down the path. So you can't wait 2 years, obviously, for it to come up to the Ministry of Health. It's going to have to be pushed down, but it can't often be pushed all the way down to the individual provider or to the clinic. There needs to be a system which is monitoring these kinds of things and can pick up the slight changes in signal to noise ratio that signals an onset of some sort of an outbreak. I think the other thing that's really an important issue that comes up is timeliness of this data. And so, we suffer one problem in the retrospective data entry, in that if you don't keep up on your data entry people and they're not inputting the data quickly into OpenMRS or whatever system, there's a tendency, well, it's only 1 day, well, maybe it's 2 days, then it's 3 days, or we're actually a week behind in doing. You can start to see how that could quickly snowball and become a problem. Probably snowball's not probably a good metaphor to use here.
Lesotho, perhaps.
In Lesotho. The other thing is that the notion that the data is timely for sort of clinical use and decision making is also important. So you have to keep those in mind, and so we don't have very initially extremely high expectations on surveillance for this kind of a thing. But to answer your question about cluster sampling or sentinel survey type work versus the ongoing cases, I think I was talking to Thomas last night from CDC, is that the sentinel surveys, this approach at sort of sampling, has been notoriously bad at really either predicting or accurately describing these data. And as an epidemiologist, and I'm not a professional one, but I'm in the Department of Epidemiology, you know, we talk about all these techniques to actually do it. I think there's nothing better than sort of regular collection of data, because you don't also know when the thing is going to happen. So if you're sort of trying to sample at times, you can completely miss things that are happening. There's no question there's a cost to that, and that the clinicians themselves cannot be the ones burdened by collecting all the data all the way up the system that what people want. But on the other hand, we do want to try to regularize that system and building such data that if you look at the Health Metrics Network's framework, you don't need all the data elements at the top in all the quantity, but you do need to start collecting all the data elements at some point, and then they kind of, as you move up the system, the more important ones get picked. And then as you need to, you can always go back down and get more. But that's one way to kind of think about the balance.
About 8-9 minutes left.
Thank you. I'll ask, Hamish would like, anybody else, please, if you'd like to ask a question or answer, please come down. Either that or we're all going to get out of this circle and they'll be looking at empty chairs for the next section.
We need more fish in the bowl.
I just wanted to expand on what Hamish said. He mentioned the the use case of mapping stockouts. Just if you're interested in the technical perspective, you can go to stopthestockouts.org and actually look at the map. It was done using a mapping engine called Ushahidi. They used Frontline SMS to map everything. And in the very near future, Frontline SMS will finish the integration of Frontline SMS with OpenMRS. So even when you are regularly aggregating data, the current practices takes some time, like weeks, if not, on a monthly basis. But you could potentially, choose specific data that is more time sensitive. If you're running Frontline SMS with your installation of OpenMRS, actually just have Frontline SMS, generate a report on a daily, on a weekly basis, and have it send that information to whatever central location via SMS or GPRS. If you don't want to wait until the rest of the process has happened.
I should mention that I keep forgetting that you work for Frontline SMS, so I was just commenting on something I'm particularly interested in. It wasn't meant as a plug.
Well. Gilbert.
Thank you.
Yeah.
Sorry. First of all, interested in standards. I know Andy has been working on these things, and trying to map them with the concepts in some ways. So I don't like people who have this vision of beginning these primary care implementations. If you can have a standard of collaborations and see how we can start with doing this, because it's that's where the first steps are at before going ahead. So I don't know how we can have kind of discussions and then keep it so that we can begin with good ways of implementing primary care.
This is the first step in that. I would just say from our point of view, and I think I can say this for PIH as well, but we're willing to share everything, the forms, the concepts. If there's a way that we can help both discuss it from learning lessons as well as actually getting you started, whatever we need to, we're happy to. Now, you want to talk about Rwanda a little bit at all, or do you want to just mention a little more about what you guys are?
Sure. So just to follow up on that, so Gilbert is working. We're working with Gilbert and his colleagues in the health ministry in Rwanda to develop the strategies for collecting primary care data. And as I think I mentioned earlier in the week, this is part of a strategy for primary care in Rwanda, which is based upon looking at all of the aspects of delivery of care, including a focus on use of community healthcare workers and effective supply chains for drug supply, training programs focused around not only physicians but the other healthcare workers, including nurses and community healthcare workers and so on, and information systems, and basically EMR for primary care is part of that larger strategy. And we're just in the moment in trying to work on that issue. Wondering if Richard might like to comment on that at all. We were in the fishbowl, Richard, and we need some more fish. Sorry to put you on the spot, but it's just nice to hear the perspective.
Thank you. I'll focus on primary healthcare package, which we are still refining up till now, but it's mainly to based on the existing OpenMRS system which we have, which is mainly HIV, but also include other functionalities like lab data, which is not only HIV lab data, but lab for all the other diseases, pharmacy, which includes dispensing and stock management of the drugs, and also, I think Cheryl mentioned about it, producing mutual data, and I think had a very good comment. Either we get data entered by the mutual or entered by the through the clinical entry forms. That is something that we can review. Yeah, so those are the key elements that we want to enter into the existing OpenMRS system, and perhaps in future we shall be building on that a bit further.
Thanks.
Good fish. We have about 4 minutes. Anyone else has a question, comment?
2 actually. Yeah.
Oh, come on in, Robbie.
I'm keeping time.
No, you can't. You have to still come out.
2 minutes, not 2 comments.
Oh, 2 minutes. Oh, I thought you said. Darn it! I thought I have 2 comments. We could laugh about that for 2 minutes now. Okay. Good.
Let's finish it.
Yeah, I have one more comment. Just
Thanks.
like sometimes when we say like we want to like correct the primary care data, is sometimes to satisfy some reporting, some indicators at the central level. I don't know how you do, because sometimes someone wants to see if I have like these indicators I need at the central level, how can I correct information on the primary care so that I can get these indicators?
Exactly.
So I don't know if you were like a certain way of designing this kind of document to show how these things can move together, but can give like a clear directions on when someone is designing a system to see how feasible it will be.
Well, JJ mentioned a little bit, that was kind of our approach initially, which was to look at the reports and then build back on the form. What we found out is that a lot of the things on the form, or sorry, on the reports, are not really very useful, but we have to do that for the ministry requirements, although I think the point being that at some point this might all improve. But you usually have to start at least with those minimal data set that comes from those forms, and then look at what are the indicators that you in the clinic need to do for your internal monitoring. It's not exactly, it wasn't clear enough, I think, in terms of how those all fit together, and one of the things that we've now come back to, at least in MVP, is really kind of elaborating documentation that shows exactly how the indicators are built. And I think what Ola and DHIS folks, I think this is relevant to TrackNet too, is that if we can make those rules more explicit within the OpenMRS data model, then it would be possible to keep a library of indicator data, and we could share that, and that, I think in 1.5 plus we'll be able to do that, and then regularize the actual reporting out to whether it's whichever system is going to be used to aggregate the data. But A, it means having clear concept definitions and having those mapped to something that you can move between sites. 2, making sure that the way that those build into indicators is very explicitly written down. And 3, is there a process for actually monitoring and making sure that they're actually making it to the end, that you got the right indicators and the right concepts at the start to make the report at the end of the month or at the end of the week, depending. Done. Okay. Okay, last comment, or 2 last comments. Sorry.
Is this on? Yeah.
It's lunchtime.
Just to follow up on this, Andy. When I sat down with Bob yesterday, we sort of looked at this use case where you have the indicators defined in an aggregated report, right? It's implemented in the DHIS. And then, let's say you have 20 facilities in a district. 5 of them will have OpenMRS. 15 will use the paper format. You have to make sure that they actually aggregate this number in the same way. And so the aggregated report should include instructions how to get to this number, right? And it should be possible to describe that electronically and
On paper.
sort of on paper.
Yeah.
If not, the data quality could, be a real issue. So I think this, the paper system really needs to guide then the electronic system. Yeah.
Excellent. Last point.
Yeah, there's one challenge that I think we are going to face going forward. We have lots of expectations for these systems sometimes, because at one hand you want to use it as a clinical management decision-making system at a facility level, whereby, like our colleague from Uganda said, it only makes sense if you use it for chronic diseases. Then it becomes practical, follow-up encounters and so on and so forth. And on the other hand, we want to use it as a reporting tool, whereby the expectation of the ministry is they don't want to report only on chronic diseases. They also want to report acute diseases like malaria and diarrhea diseases and so on and so forth. So we might, again, since we can't make the system correct all the data, we'll have a problem with, again, collecting indicators using other systems. Then you have these poor nurses, or if you're fortunate enough to have data managers, fair enough. But then you have these people who are entering data in OpenMRS and then entering data in another reporting tool for the ministry. Yeah. So that is something that we have to strike a very good balance in.
And good standards are needed.
And of course, standards. So that's a great point to end on. So thank everybody for their contributions. Hopefully, Hamish, you got your questions answered. And I think it's lunch.